I am Dr. Giovanni Maria Colpi, an andrologist, and today we will discuss azoospermia. Azoospermia refers to the absence of spermatozoa in the ejaculation. It is a significant diagnosis. When a woman discovers that her partner is affected by azoospermia, it is often a moment of crisis, prompting a search for information online about how to manage the condition. Videos, texts, images, and opinions from many physicians concerning sperm retrieval from the testicle. My presentation will describe azoospermia from all perspectives, everything a patient and his partner need to know about the subject. This presentation will be different from those seen in the past, for two reasons. The first is that, as you may note from my curriculum vitae, I have experience in this field. I have been working specifically with azoospermia for over 35 years and have performed thousands of surgical procedures, managing numerous patients, many of whom have gone on to have children. I am the director of the Andrology Unit and the scientific director of the Andrology and Assisted Reproduction Center at Fertility, ProCrea in Lugano. I was formerly director of the Complex Operative Unit of Andrology and Assisted Reproduction at San Paolo Hospital, University of Milan, likely the most important public center dedicated to severe cases of male infertility. I have lectured at various Italian and international universities. I am a full academician of the European Academy of Andrology and a senior advisor for the Global Andrology Forum in Ireland. I have also been a member of the male infertility committees of two European scientific societies, the European Academy of Andrology and the European Association of Urology. I also hold other scientific positions, which lend further authority to the information I am about to present. Sperm are produced inside the testicle, which, as shown here, is organized in lobular segments. Each segment is a lobule, and within each lobule are seminiferous tubules. Inside these seminiferous tubules, sperm production takes place through a process known as spermatogenesis. In this cross-sectional view, we observe immature germ cells called spermatogony, which then mature into primary spermatocytes, secondary spermatocytes, and finally spermatozoa. This image is key to understanding what follows. When spermatogenesis is normal, the seminiferous tubule is densely populated with germ cells and thus maintains a specific diameter with only minor fluctuations. When spermatogenesis is defective, there is a partial depletion of the germinal population, resulting in a narrower tubule. In the case of complete germ cell depletion, such as that seen in Sertoli cell-only syndrome, the seminiferous tubules are markedly atrophic with extremely thin diameters. Azoospermia is classified into two main categories: obstructive azoospermia and non-obstructive azoospermia. In obstructive azoospermia, spermatogenesis is completely normal, but the seminal pathways are either blocked or absent. In such cases, except for rare situations where the obstruction can be surgically corrected, treatment typically involves retrieving sperm directly from the testicle, either via needle aspiration or TC, testicular sperm extraction, which involves obtaining a small tissue sample to search for sperm to be cryopreserved or used in assisted reproduction. Alternatively, sperm may be retrieved from the epididymis above the obstruction, either via percutaneous aspiration or microsurgical technique. In contrast, non-obstructive azoospermia is an entirely different condition. In these patients, spermatogenesis is severely impaired, resulting in the absence of sperm in the ejaculate. At first glance, this may suggest that the patient is entirely incapable of producing sperm. However, this has proven not to be the case. In fact, studies have shown that in a high percentage of patients, estimated at no less than 60%, residual spermatogenesis may persist in tiny, scattered foci within the testicle. Therefore, the andrologist's goal is to identify and retrieve sperm from these residual foci. There are predictive factors, i.e., parameters, that may help determine in advance whether a patient is likely to have residual spermatogenic foci. Traditionally, testicular volume and FSH levels have been considered as such indicators. Admittedly, very small testicular volume is often associated with more severe damage, leading to the assumption that the prognosis is poor. However, this correlation is not absolute. Indeed, some patients with extremely small testes, comparable in size to beans, have still yielded sperm cells. Many of them have successfully fathered children via ICSI, intracytoplasmic sperm injection. Another parameter is FSH, follicle-stimulating hormone. Elevated FSH levels in the blood are generally thought to indicate more extensive testicular damage and, consequently, a worse prognosis for sperm recovery. Yet even this assumption has proven to be unreliable. We have encountered patients with non-obstructive azoospermia and normal FSH levels, as well as patients with markedly elevated FSH in whom sperm were successfully retrieved and later used in IVF. In one case, spermatozoa were found in a patient with an FSH level over 80. In these patients with non-obstructive azoospermia, as illustrated in this slide from the Mayo Clinic, the aim is to identify seminiferous tubules that still maintain a normal diameter, which could indicate the presence of residual spermatogenesis, in contrast with the majority of tubules that appear thin and atrophic. To illustrate this concept, consider the following analogy. Imagine a man comes home one evening and his wife tells him, "Darling, I made vegetable soup." The soup contains numerous types of vegetables, but she warns it may contain very few beans, or perhaps none at all. Would you feel confident determining whether the soup contains beans based solely on a single ladleful poured into a bowl? If you are lucky, that portion might contain a bean or two, but it might just as easily contain none, even if there are beans elsewhere in the pot. However, if you use a different approach, for instance, by pouring out half the pot into a large bowl, it becomes much more likely that you'll find any beans present. Not only that, but your overall yield would be far greater. This is precisely what occurs when comparing different surgical sperm retrieval techniques. What are the available surgical techniques for patients with azoospermia? One procedure that is still improperly used, despite being excluded from international guidelines, is testicular fine needle aspiration (FNA). FNA is no longer recommended for non-obstructive azoospermia by both the European Association of Urology and the 2024 Canadian Guidelines. Another alternative is testicular mapping via multiple FNAs from different sites within the same testis. However, even this approach is no longer recommended as a primary therapeutic option for non-obstructive azoospermia. The next technique is TESE, which involves excising small fragments of testicular parenchyma. This may be done as a single biopsy, with larger tissue samples increasing the chances of finding spermatozoa, provided that sperm are actually present in the sampled region. The downside is that larger biopsies carry greater risk of damage to the testis, since not only germ cells but also testosterone-producing cells may be removed. Some surgeons prefer taking multiple small biopsies from different testicular areas, as shown in this slide. However, it is important to note that each biopsy removes testicular tissue, and surrounding tissue inevitably undergoes fibrosis, resulting in the loss of parenchyma. Tissue that houses both germ cells and Leydig cells, which are responsible for testosterone production. The standard TSE technique assumes that residual spermatogenesis, if present, is distributed homogeneously throughout the testis. However, this has been disproven by numerous histological studies. On the contrary, MicroTESE, microdissection testicular sperm extraction, as its name implies, is a microsurgical procedure based on clinical and histological evidence that the testicles of men with non-obstructive azoospermia often show a patchy distribution of residual spermatogenesis. For example, this histological image of a testicular biopsy clearly shows, highlighted by the green arrow, seminiferous tubules of normal diameter containing active spermatogenesis. In contrast, other tubules appear narrower and completely devoid of spermatogenic activity. At higher magnification, we can again observe this pattern. One tubule contains only Sertoli cells and no germ cells, while the adjacent tubule exhibits preserved spermatogenesis. Here you can see an image from the operating microscope. The thin seminiferous tubules are visible here, alongside a dilated tubule, which contains spermatozoa and residual spermatogenesis that was subsequently excised. In the years following Schlegel's initial 1999 publication, demonstrating the effectiveness of MicroTESE for retrieving sperm in patients with non-obstructive azoospermia. Side note, Schlegel first showed these slides to me in 1998, and I began performing microsurgical retrievals that same year. Numerous studies have been published, focusing on the technical details and the steep learning curve required to achieve high retrieval rates. This study by Ishikawa, 2010, already showed that after the first 50 cases, the average sperm retrieval rate was 32%. After another 50 procedures, it rose to 44%, and after an additional 50 procedures, it rose to 50%. 50 cases, it reached 48%. This suggests that at least 150 cases are necessary to begin achieving consistently acceptable success rates. Moreover, surgical time is also a crucial factor. The longer the exploration, the higher the chance of finding sperm. These early studies by Ramasamy from Schlegel's group, 2011, document that on average successful retrieval required nearly 2 hours of surgery. In cases with negative results, procedures often lasted even longer, since the surgeon keeps searching before conceding failure. Not only is microsurgical expertise essential, but biological processing is just as important. It is unacceptable for a couple's chance to have a child to hinge on a biologist who may only spend a few minutes analyzing the sample, quickly declaring that no sperm are visible or that none are usable. Ramasamy emphasized the importance of extended examination times, sometimes lasting several hours, using advanced mechanical preparation techniques. This study by Deriva was the first major publication in the literature to demonstrate that MicroTEC is far more effective than conventional TZ in terms of surgical sperm retrieval rates. In cases of Sertoli cell-only syndrome, MicroTEC achieved a 37% retrieval rate versus 14% with TESE. In maturation arrest, MicroTEC reached 49% versus 27%. In hypospermatogenesis, 85% versus 73%. Overall, MicroTEC yielded sperm in 54% of patients with non-obstructive azoospermia, compared to only 33% with conventional TZ. Of course, MicroTEC has specific requirements. It demands a microsurgical setup. Here you can see a microcoagulator with a 2mm tip and a high-quality operating microscope, along with specialized biological processing. In these images, you can observe the embryologist mincing the initial testicular tissue fragments, then almost pulverizing them to create a suspension in which sperm cells are subsequently searched for. As you may notice, several of the slides I am presenting are marked CU World Istanbul, October 11th to 14th. These I presented at this year's International Urology Congress in Istanbul. A highly prestigious event featuring 3 entire sessions dedicated to andrology. I was honored to deliver 2 lectures, one on surgical sperm retrieval in general, and one specifically on MicroTEC. I was also invited to present a surgical video on the technique and to participate as an expert in a panel discussion on MicroTEC versus conventional TSE. Thus, the content I am showing here was presented before an international audience of experts. These are not personal opinions, but rather reflect the current state of scientific evidence. What are the secrets to achieving a successful sperm retrieval through MicroTEC? First of all, it is essential to properly prepare the patient. One should not rush into MicroTEC immediately after diagnosing non-obstructive azoospermia. A thorough medical history must be taken to identify any recent risk factors, such as exposure to excessive heat, recent episodes of fever, or contact with potentially harmful chemical substances. Next, the patient's testosterone level must be checked. There is strong evidence suggesting that normal testosterone levels increase the likelihood of finding sperm within the testicles. This is critical, as approximately 40% of patients with non-obstructive azoospermia present with either markedly low testosterone or low normal levels within the physiological range. As previously mentioned, another key factor is the surgeon's learning curve and experience. Schlegel maintains that it takes at least 500 procedures for the surgeon's eye to become sufficiently trained to detect even the most subtle differences in tubule diameter, differences that may determine whether spermatozoa are present or not. In fact, the Canadian guidelines from 2015 already stated that testicular sperm extraction should be offered to all patients with non-obstructive azoospermia, but only in centers with specific experience in MicroTESE and where the ICSI laboratory has expertise in handling such delicate samples. This is an absolutely crucial point, and I would say a fundamental requirement. As I mentioned earlier, I have personally performed over 1,700 MicroTESE procedures, placing my experience among the highest internationally. In recent years, multiple new techniques have been developed to improve the efficiency of the original procedure described by Schlegel, particularly in the tissue processing phase for sperm retrieval. This slide shows a long list of these optimized techniques, which I presented in Istanbul. These methods significantly increase the number of viable spermatozoa obtained from a single tissue fragment, far more than what was initially possible. In our center, we have been using collagenase for many years as part of our protocol. Here are the first data we presented at the European Congress of Human Reproduction in 2020. Thanks to collagenase, we were able to retrieve, on average, 3.5 times more viable spermatozoa than when using mechanical methods alone, without enzymatic digestion. Ultimately, the most critical aspects of a successful MicroTESE are both experience and the available technology. Very few centers worldwide, compared to the number of centers performing TC, carry out MicroTESE with extensive expertise. Most of them work at 18 to 24x magnification. We are among the very few that operate at 36x magnification. This difference is clearly visible in these images. The same testicular tissue viewed at 24x versus 36x magnification. This is an extremely important detail. As explained earlier, the likelihood of finding sperm depends heavily on the diameter of the tubules, and thus it is vital to have a calibration tool available. This is a gauge that we introduced into surgical practice, and according to our experience, its diameter represents the minimum threshold necessary to have a real chance of finding sperm within the tubules. If the extracted tubule has a larger diameter than this benchmark, the chances of finding sperm increase significantly. At higher magnification, 36x, you can see here that none of these tubules match the required diameter, and therefore the probability of recovering sperm from them is extremely low. Let us go further and compare various tubules using this same gauge. Some tubules have a slightly smaller diameter. Others fall into the borderline range, and some clearly exceed the threshold. In tubules with significantly larger diameters, the probability of sperm retrieval can reach 90% or more. For those at the borderline, success rates are around 80%, and as the tubule diameter decreases, the retrieval rate correspondingly declines. In the past, I have heard numerous patients report negative comments made by various colleagues regarding MicroTESE. Unfortunately, many of these remarks are biased, typically originating from clinicians who do not perform MicroTESE themselves. Statements like, MicroTESE causes severe damage, they split your testicle in two, it's incredibly painful, are all misleading and entirely false. These are the official guidelines from the European Association of Urology, EAU, published this year. They clearly state that MicroTESE results in fewer post-operative complications compared to TESE, and that its negative impact on testicular function is also less significant than that of conventional TESE. If we look at our own clinical experience, already in 2009, we presented a series of 360 MicroTESE cases at the Scandinavian Andrology Congress in Aarhus. In that cohort, there were no hematomas, no local infections, no cases of chronic post-operative pain, and only very rarely did patients report mild discomfort in the immediate post-op hours, an extremely rare occurrence. These results are due to the meticulous care we apply during surgery. For example, capillary bleeding is often managed with gentle compression using gauze, rather than with the microcoagulator. Additionally, the tissue is irrigated with antibiotics and corticosteroids. As a result, the vast majority of our patients require no analgesic medication post-surgery, most report no pain, and only a small number may take a single dose of paracetamol within the first 24 hours. A particularly interesting aspect comes from a recent publication by Schlegel, the inventor of the MicroTESE technique, who challenged a long-standing dogma. In the past, many biologists claimed that immotile or morphologically abnormal sperm could not be used for ICSI, intracytoplasmic sperm injection. In contrast, Schlegel conducted a study using spermatozoa that were either immotile or had acrosomal defects, but were alive. Here are the outcomes. When sperm were immotile but alive, fertilization occurred in 48% of oocytes, with a 44% clinical pregnancy rate. In more compromised cases, with immotile but viable sperm, fertilization was 20%, with a 19% clinical pregnancy rate. Even sperm with acrosomal defects achieved 35% fertilization compared to 49% in normal cases and 27% clinical pregnancy versus the usual 44%. We, too, have occasionally used non-motile or morphologically abnormal but viable sperm in situations where no better options were available, and we have achieved successful pregnancies and healthy live births. We, too, have had our own influencer, a Turkish colleague, who demonstrated that pregnancy rates from ECSE using surgically retrieved sperm should be considered in terms of cumulative pregnancy. This means that if sperm are successfully retrieved and used to fertilize oocytes, multiple embryos may result. These embryos can be transferred one at a time, allowing for multiple pregnancy attempts from a single sperm retrieval and oocyte pickup cycle. So, even if a woman becomes pregnant after the first embryo transfer, she may still have additional embryos frozen, which can later be used to attempt a second pregnancy. If the first transfer fails, she may try again with a second or even a third embryo. As shown here, the cumulative pregnancy rate, once sperm have been successfully retrieved, is very favorable, especially when we consider that patients facing a diagnosis of azoospermia often feel hopeless and assume they will never become fathers. We also faced another important challenge, Historically, like most of the few high-volume MicroTESE centers worldwide, we used to cryopreserve spermatozoa after retrieval. These frozen sperm cells would then be thawed at the appropriate time for use in ICSI. However, both freezing and thawing lead to an unpredictable loss of spermatozoa from the initial sample. On average, 2/3 of the sperm are lost in this process. For some patients, the loss may be smaller, but in others, it can be substantially greater. In fact, in approximately 1 in 100 patients, all sperm may be non-viable after thawing, making them unusable. This issue becomes especially critical when only a few spermatozoa have been retrieved, each one of which is extremely precious. Once frozen and thawed, these few sperm may become extremely scarce or even non-existent, significantly reducing the couple's chances of achieving pregnancy. In 2019, Sengia proposed an important idea. If we could use fresh sperm for in vitro fertilization, it would be a far more effective strategy. But what does this imply? It involves major logistical planning. From that moment on, the woman's ovaries dictate the timing of the entire process. This means that the man is prepared. The woman undergoes ovarian stimulation, and about 36 hours before ovulation, the entire surgical team is alerted in order to schedule the MicroTESE procedure in alignment with the oocyte pickup. Keep in mind that a MicroTESE procedure typically takes 2.5 hours in the operating room. With setup and turnover time, this becomes 3.5 hours in total. This poses a significant burden on the medical facility, and in most hospitals, it is virtually unfeasible. Hospitals have multiple specialties sharing operating rooms, each with their own surgical needs. These are generally scheduled a week or two in advance, making it almost impossible to accommodate a couple's last-minute need based on a woman's ovulation schedule. At ProCrea, fortunately, we have 2 dedicated operating rooms, and because we are a fertility clinic, not a hospital, our sole focus is reproductive medicine. As such, despite the substantial organizational effort, we are able to synchronize the male's MicroTESE procedure with the female's oocyte pickup, allowing for the use of fresh sperm during ICSI. These are the data we presented once again at the Istanbul Congress. As shown, when spermatozoa are successfully retrieved and in vitro fertilization is performed with fresh sperm, the fertilization rates are comparable to those reported by Schlegel. Of the fertilized oocytes, 42.5% develop into blastocysts, embryos with a high potential for successful pregnancy. So, for example, if a woman produces 3 blastocysts, she has an initial 35% chance of achieving a pregnancy with the first embryo transfer. If that transfer is successful, she still has 2 blastocysts remaining, which can be used in future years to attempt a second pregnancy. Alternatively, if the first transfer fails, she may proceed with a second or third attempt. This graph shows that the rate of ongoing pregnancy is strongly correlated with the number of blastocysts transferred. As can be seen, the overall success rate is extremely favorable. Let us not forget that if the woman exhausts all her available blastocysts, we still have a supply of cryopreserved straws from patients who have undergone MicroTESE. Therefore, We always have multiple pilettes of frozen sperm stored and available, allowing the couple to attempt another round of in vitro fertilization at a later time. By combining the cumulative pregnancy chances from a single oocyte pickup with fresh sperm, along with the additional opportunities from thawed frozen samples, we can say that a very high percentage of couples eventually succeed in having a child. To conclude, this final slide was presented jointly by myself and Professor Kadiu of Istanbul at the SIU World Congress. We concluded with the following statement. MicroTESE should be considered the only appropriate procedure for sperm retrieval in cases of non-obstructive azoospermia. And the answer to that question is unequivocally yes. In clinical practice, it is not uncommon to encounter patients who have previously undergone conventional TESE, even though this approach is now considered inappropriate as a first-line treatment. The problem is that obviously TC, as you have seen, gives a positive recovery in about 35% of cases, and if the sperm that were frozen after this TC run out, obviously the subject can undergo another TC. The problem arises, and it's the patients who come to us, when we have patients who have undergone TESE without surgical recovery. In this case, with a negative recovery, the patient can undergo MicroTESE. International data, fully consistent with our own experience, show that in patients who failed a prior TESE, a subsequent MicroTESE yields sperm in 42% of cases with a positive result. For patients who are surgically naive, i.e., with non-obstructive azoospermia who have undergone undergone prior surgery, our current success rate is 59.5%. That said, if a patient has already undergone a properly performed MicroTESE with no sperm found, it is unlikely that a repeat attempt would yield a better outcome. After all, MicroTESE represents the most advanced, meticulous, and effective technique available today. If a well-executed MicroTESE fails, no one would reasonably propose repeating it using conventional TESE. This is further indirect proof that MicroTESE is the gold standard and the most appropriate and recommended procedure for patients with non-obstructive azoospermia. It certainly is not TESE, and even less so fine needle aspiration, which, as discussed, is no longer included in international guidelines. To close, I would like to thank all the members of my team, Doctors Castiglione, Nerva, Piatti, Bellavia, Taccani, Momi, Cuomo, Antonacci, Zehaf, and Mattavelli, as well as my consultants, Dr. Caroppo and Dr. Gazzano. Thank you all for your attention.